Okay, so these lectures are from the Orthopedic Trauma Association. And do I make this full screen up here if I do anything like do this?
I think because you're not. Yeah.
No, doesn't matter. Okay. All right. From the Orthopedic Trauma Association's series, we're going to go through, and hopefully we'll get down to forearm and wrist. We're not going to cover hand in this section, so Dr. Lochner has a hand talk as well. But pediatric forearm fractures are a significant part of children's long bone fractures, about 40%, and most of them are from a fall to an outstretched hand. The ulna is particular in that it's susceptible to a direct blow. It's a subcutaneous bone, and so it can be injured from a direct blow, either from being struck in a so-called nightstick fracture. Not that police are using nightsticks much anymore; they're just kind of shooting now. But you can break your ulna from landing directly on it, or landing on like landing on a curb or landing on anything that's raised. And then forearm fracture incidence is also increasing because of the increased sporting activity and increased body weight, what I call the dueling epidemics in pediatric orthopedics. So if you take the Venn diagram of increased sporting activity by children and increased body weight, then the intersection of those two has a whole bunch of things in it, like increased rates of slip capital femoral epiphysis, increased rates of fracture. A whole bunch of really interesting things exists in that sort of like overlap area, and that's why I'm interested in BMI for the study that we were talking about. So, and neurologic injury is relatively rare with pediatric forearm fractures. So locations, the proximal part of the forearm is much less common, so about 4%. Even though we have one of those on the schedule today, because of a decreased lever arm and a big soft tissue envelope. Midshaft, about 20%, and distal is really the lion's share. So, we see these day in and day out in our clinic, about 75% of radius and or ulna, and about 15% of those are in the distal physis. And the different fracture types, so plastic deformation, which we'll talk about in a little more detail momentarily. In plastic deformation, there is no visible disruption of the cortex, but the stress is higher than the elastic limit of bone, but below the fracture threshold. The incomplete or greenstick fracture, so one cortex is intact and the other cortex is broken, and we're going to include buccal or torus fractures in this subgroup. And then the complete fractures, so more unstable, both cortices are broken. So the goals of treatment are to restore the alignment and the clinical appearance. It's very important how the arm looks. It's a very good guide for whether your treatment is successful or not. Couple that with an understanding of how things are going to remodel, and that's really the sort of goal. That's your guide to how to treat pediatric forearm injuries. You want to limit the injury to the local soft tissues, i.e., prevent compartment syndrome, prevent further injury, relieve their pain, and then make sure that you end up with functional forearm rotation, which is 50 degrees of supination, 50 degrees of pronation, which is what's necessary for normal activities of daily living. Normal is 90 and 90 of those two. So you'd like to get them back to that if possible, but you can live with 50-50 or 45-45. So the primary ossific centers appear at about 8 weeks of gestation in the radius and the ulna, and most of the longitudinal growth is provided by the distal growth plate in the radius and the ulna. The proximal growth plates really do not provide much of the longitudinal growth. The distal epiphysis of the radius appears at age 1. For the ulna, appears at about age 5, and that's important because you will not see a distal growth plate at the ulna in a child who has a fracture. They may have a fracture of the distal ulna that you don't recognize. So this is plastic deformation. You can tell that this bone is obviously not straight, or not as straight as it should be. It looks obviously curved and bent, but it's not clearly broken anywhere. And this is an important concept to understand. So this is a typical stress-strain curve for any given material. Bone's a composite material, so all of that's taken into account when this is when these curves are constructed. And so within this area where this stress-strain curve is straight, essentially the deformation is what we call elastic, right? So you apply a stress, you apply a force, you get a deformation, and when you remove the force, the deformation is eliminated, and then the time it takes to get that may be a little bit slower. There's this problem called hysteresis or creep, that it may take longer for it to get back to normal than it did to deform, but eventually it'll get back to the original shape. And so if you apply a force to a bone in this elastic range, you would expect that it'll go back to normal. So if the child falls and the amount of force that's applied is within this zone, then you will not expect the bone to fracture. However, if the force that's applied is beyond this elastic limit, then the deformation will become permanent. And so as long as the force is applied somewhere between here, the elastic zone, and here, the fracture point, and you can imagine of all the millions of times that children fall each day, that some of them are going to end up just in this zone and not cause a fracture, that you're going to end up with some cases of plastic deformation in which the bone is now permanently deformed but not broken. These are most common in the forearm because of the fact that the forearm is the one that's taking the entire body weight. I guess theoretically this could happen in any bone. It could happen in your tibia. It could happen in your femur. But the mechanism for that is sufficiently unusual that it doesn't happen with an appreciable incidence. But with the forearm, it's something that we see frequently enough. So the periosteum remains intact, which means that there's going to be no callus formation, because periosteum is what determines callus formation. And the periosteum, the deformation can then limit your pronation and supination, because the radius will rotate about the ulna, and if the radius and ulna both have a new curve to them, then they may bang into each other as you try to rotate. And so this is a problem that you don't want to ignore necessarily. So the remodeling of plastic deformation is not as reliable. You can see in this picture the forearm obviously has a curvature to it, and so the criteria for treating this is if there's more than 20 degrees of angulation, if one of the bones being plastically deformed prevents the reduction of another bone, so radius or ulna prevents the reduction of another one, or occasionally you can have a deformation of the ulna, which causes a radial head dislocation, Monteja injury, so you've got to do something to the ulna to get the radial head back and back reduced. If you lack full pronation and supination in a child above age 4, any child above age 8, because the remodeling is going to be quite limited. The force required to reverse a plastic deformation is considerable. Remember, you've got to get back to this. Okay, you have to physically get the bone into this zone without going all the way here. So this is very challenging, and it's something that has to be done very carefully, and should be done in the operating room, because it's very difficult to do in a non-controlled setting. So, so I find that it has to be done almost. You almost have to put not almost. You do have to put the child's arm basically over your knee to generate enough force to bend it back, and you're just carefully, slowly bending the bones back and checking them sort of regularly on the C-arm to make sure that you've gotten enough. And you can sort of feel the trabeculae giving as you're bending. in the opposite direction because you're very slowly sort of pushing them back, and occasionally you're going to go too far and you may get a fracture, and that's something that you have to warn the family about before you do it. So here's a Greenstick fracture. You can see the intact cortex on this side and the broken cortex on the other side, and I know nobody plays outside anymore, and so so sticks are basically parts of trees that fall on the ground, and sometimes they're green because they're like not dry. And so, things from my childhood that you'll never see. You want to immobilize these in a very well molded long arm cast, and the thing is, these need a really good mold because they want to spring back to that Greenstick position, and occasionally the safest thing to do is actually to complete the fracture, so you eliminate the force of that intact cortex trying to spring it back, and if it really is continuing to spring back, then you may want to do that. But I would recommend only doing that under sedation or in the operating room. So, because you're now going to create a more unstable fracture, so you should feel very comfortable that you have the ability to hold that in a reduced position. So, and then looking back at this, obviously you can see the contour of the skin right here. Right, so the skin contour looks relatively normal. So this is going to be very well tolerated. This is an apex volar deformity, so volar being towards the palm side. These are very well tolerated. Apex dorsal deformities are very visible or not very well tolerated. So the family will be like, his arm looks crooked. Here, they really won't notice much. They won't say anything, and this will remodel very nicely. So this is a complete fracture. Both bones are completely broken, radius and ulna. This is a very unstable injury. They're also broken at 2 different levels. And this is going to be very difficult to reduce and hold on to. So there's no stability to length, no stability to rotational alignment. The muscle forces are going to be more of a deforming factor. There's more soft tissue injury. There may be soft tissue interposed. Muscle forces that apply to different fragments. So the biceps in this case is going to be acting as both a supinator and a flexor of the proximal fragment. And so the proximal fragment will be flexed up and supinated, and so you're going to try to match that. But the problem is that the distal fragment is going to be pronated by the pronator, and so how do you accommodate for that? It becomes very challenging. So the method for closed reduction of most of these fractures is there's a number of different methods for doing this. You can do them under conscious sedation. You can do them under beer block, which is a tourniquet-induced local anesthetic in the extremity. You can use general anesthesia. There's the concept of traction and countertraction. So when I was a resident, what I would do is put them in finger traps and then use my water bucket as the countertraction. So I would hang that on the arm with a big pad. And so I had the arm up here and the water down here, and so I had both hands free, and something was kind of pulling in the opposite direction for me, and that was it, either with sedation or with a local block if it was a distal radius fracture. But for forearm fractures themselves, you need a little more help than that. You then want to reproduce or exaggerate your deformity to see if you can unlock your fragments. And this is much easier if the fracture is relatively new, within the first few hours. And then try to lock your fragments in place with the periosteal hinge, and then correct your rotational deformity. And so the way to think about this is that you want to point your thumb into the apex of the deformity, right? So if the apex is volar, you want to pronate, right? If the apex is dorsal, you want to supinate. So wherever the apex of the fracture is, you want to point your thumb into the apex, and that should really assist with your with the correction. A lot of people are very nervous to do something like that, and they just want to end up in neutral. And neutral is a position of weakness, right? Because you have not committed to doing something. It just means that you don't really understand or believe that this works. So you really should either pronate or supinate if you have a both bone forearm fracture in the middle, unless it's perfectly lined up. Okay, in which case that's fine. But if it's displaced, then you should definitely try to either pronate or supinate as long as it has an apex. And it really does work. If your reduction is not appropriate or it's not acceptable after you've done that, then the patient's going to need to be treated probably in the operating room anyway. But you may be able to get a very nice reduction for them if you understand the principles. So these generally need about 6 weeks of casting, and that's what you should tell people. You can convert them to a short arm cast at 3 to 4 weeks if the healing is adequate. I would never mention that to a family. I would tell them the worst possible scenario of casting because it's all about managing expectations. So tell them 6 weeks, 7 weeks, that you're going to be in a long arm cast for 8 weeks, and then when you take it off at 6 weeks, they think you're the best person they ever met. When you tell them that it's going to be 5 weeks and they have to wear their cast for 6 weeks, they think that you are like, an ogre and you're torturing them. Okay, so it's all about managing expectations. And if you tell them they can have a short arm cast after a few weeks, then they hate you if you don't do that for them. So, and when you think about all the extra work that goes into converting a long arm cast to a short arm cast, on the thousands and thousands of forearm fractures that occur, there was a study done at LA County, and they found that at 6 months there was absolutely no difference in elbow range of motion whether you were treated in a long arm cast for 6 weeks or a long arm cast for 4 weeks and a short arm cast for an additional 2 weeks. It didn't make a difference for range of motion, but it did make a difference for the amount of time and energy that went into converting casts. So, remember, malreductions as you go more proximal in the forearm will limit rotation by increasing amounts. So this is a very nice reduction. This is a distal radius fracture with an ulna fracture as well. These are easy to get if you have the right amount of assistance. You don't necessarily need another person, but you need traction and counter traction. You need to get to this early, and you need to make sure the patient is relaxed, and you need to give it some time to be able to kind of pull these two pieces apart, make sure the patient is comfortable, and then you can get this reduction, and that's a great cast because all the molds are in the right spot. You can see here that this mold, let's see where my mouse go. Oh, here it is. I can see it. Okay, you can see that the this cast is not beset with excess padding, and you do want enough padding to not cause a cast injury, which we'll talk about in a second. But also the cast is well fitting. There's a mold right here. There's a mold right here. So this cast has a very good chance of being successful at treating this. The wrist is slightly flexed, so that's a very good cast. It's a great reduction. It's going to work well. So, how much angulation is too much? This is always the sort of challenge in pediatric orthopedics because in adult orthopedics it's simple. It has to be perfect. But in pediatric orthopedics there's a range of what's acceptable, and so that's part of the art of knowing what you can accept. So it depends on the fracture, the location, the age, the stability. And there's a fair bit of disagreement on what you should accept. I think if you're going to remember any number at all, I would say the number is probably closer to 25, that you should never accept anything more than 25 in general anywhere. Another good thing to understand is if you can get a good view of the interosseous space, don't accept anything that allows the two bones to come into contact with each other. So there should be there should be enough space for those two bones to pass each other without contacting. And then like Dr. Jones always says, he likes to look at the forearm. So any angulation that's clinically apparent is not acceptable. So this is from a paper by Jim Noonan, which gives you a sense of the angulation that's acceptable by age. So less than 9:15 degrees, greater than 9:10 degrees. Malrotation, less than 9:45 degrees, greater than 9:30 degrees. Shortening, usually not an issue, including bayonet apposition, which is perfectly acceptable and remodels actually very, very quickly and may eliminate some of your angulation problems because it takes the tension off the muscles, which are what causes angulation. So, remodeling potential, there's a lot of remodeling potential in pediatric fractures. So number one, the age of the child. So if you have at least 2 years of growth remaining, you have a lot of remodeling potential. Distance from the fracture to the metaphysis. So the closer you are to the physis, the closer you are to the growth plate, the more remodeling potential you have. So the further you are away, so in the proximal third, you're much less remodeling is going to occur. The growth plate will correct about 1 degree per month, so about 10 degrees per year. It seems as though if your deformity is bigger, the more angled, then the growth plate will actually correct more degrees. So there was a paper from Cincinnati in which they wanted to discover the fate of severely angulated distal radius fractures that were accidentally sent out from the emergency room. And they tracked a bunch of these down, and they were sent out with 45 degrees of angulation, and they all seemed to remodel back to normal when they tracked them down. So what to do with these after closed reduction and casting? So weekly x-rays for 3 weeks to confirm that their alignment and rotation is acceptable and that they're now set up. And you can remanipulate these up to 3 weeks out. And that's the reason to keep checking on them. So if at 3 weeks they look acceptably aligned, then that's fine. You can ride them out for the last 3 weeks and they shouldn't move. If they are not acceptable at 3 weeks, then you should change them. Because that's relatively easy to do versus trying to change a bone that is now fully healed in an unacceptable position. And then remember that bayonet apposition is acceptable. So, maintaining your reduction in a long arm cast. So the casting technique is important. So you want a 3-point mold. So you'd like to have at the fracture. So a mold above, below, and then a counter mold on the contralateral side. And when it comes to long arm casts, you'd want your cast to be oval and not round, because fiberglass casts in general want to be round. That's what the material is like. It tries to become round when you wrap it, and you need to make it oval shaped. Okay, and so there's a cast index, which is the sort of the width of the cast divided by the height of the cast. You'd like that ratio to be 0.8. The closer it is to 1, the more round your cast is. So you'd like it to be 0.8 or below. And that also takes advantage of what's called the interosseous mold. And the interosseous mold is a very, very helpful thing. It pushes the two bones apart, and that helps you with your reduction. You'd also like your ulnar border to be straight, perfectly straight. So if this ulnar border has a curve to it, then your ulna is going to fall into that space and become angulated. And so we even used to have sort of like a wooden board with a handle on it that you could apply to the ulna while you were making this cast to make sure that your ulna ended up straight. But that's something that you really have to watch out for, because if you, in the course of trying to make everything else in your cast turn out right, allow the ulna to have a curve to it, then the ulna will fall into that space. And then, you'll have done everything else right, but then your ulna will angulate. So it's a challenge to make a very good long arm cast. Now, if you do a both bone forearm fracture reduction in the emergency room under sedation, this is the number one risk for a cast saw burn of any fracture that you treat. Okay, the reasons being that number one, the child's sedated, so they can't tell you that they're being burned. The child's not being cut by your cast saw if you're bivalving this cast. The cast saw is not cutting through the fiberglass and then cutting through the web roll and then cutting the child's skin. That's not what's happening. What's happening is that the fiberglass is still a little bit wet, and your cast saw, as a result, is heating up, and the heat is being transferred through the web roll to the child's skin. And because the child is asleep, they're not able to tell you that the heat is being transferred to them. Sometimes they will tell you, ouch, that hurts, that's burning me. And people will sort of write it off and say, well, the child's feeling the buzzing or they're feeling the saw getting close to their skin. But what's actually happening is the cast saw is transmitting the heat to their skin. So this is a very dangerous situation. And I would say probably 95 to 100% of the cast saw burns that we've seen here in the last 7 years have been this scenario. So both bone forearm fracture, reduced in the emergency room, being bivalved, is where, and you don't find out about it for 6 weeks, right? Because we're taking these casts off at 6 weeks. So you need to do one of two things to prevent a cast saw burn in these cases. Number one, you need to make sure your cast is as dry as possible before you cut the cast off. Number two, you should use a zip stick. So take a piece of plastic that we have down there. There should be plenty of them. We bought, I think, 200 zip sticks. And they're not hard to find. We have them up here in the clinic. And I've tried to get one actually physically attached to the cast saw down there, but they tend to get lost. But it's a simple little piece of plastic that you can shove in here to protect the skin from the saw, and that'll be enough to dissipate the heat before it gets to the skin. And then you can shove it up here as well. It doesn't seem to be an issue up here because there's enough space, but it's always an issue on the forearm where there's a lot of swelling and the skin's very close. And the third thing is to have a damp cloth and to take your saw blade out regularly and just make sure that your saw blade is cooled down between every sort of run over a few millimeters. That's less reliable for me. I think having something physically interspaced between these two is an issue. I think we still haven't solved this problem, and I think it has to be solved because I would rather take kids to the operating room, frankly, to have their fractures set for malreduction than to have any more cast saw burns. And I don't want to trade compartment syndromes for cast saw burns because I don't think that's an acceptable trade-off either. But I think that we need to. This is what we call preventable harm, right? Like it's not enough to say, oh well, some kids are going to get cast saw burns. Like that's not acceptable. So this is something that can be eliminated with education. So complications of forearm fractures. Malunion is the most common, so unacceptable reduction over time. This is a classic one. You can see this degree of angulation is unacceptable. So this is sort of proximal third radius fracture that has drifted into angulation. This is going to have reduced forearm rotation. And this can be changed just by rotating the forearm. Okay, like if you catch this early enough, all you have to do is pronate this and you'll get this thing reduced. Refractures occur with an appreciable frequency, especially if the cast comes off too soon, if the healing is incomplete, if the kids are fairly rambunctious. Compartment syndrome, unfortunately, does occur. You have to watch out for it. The highest risk of compartment syndrome is in the subgroup of open both bone forearm fractures that are treated surgically within the first 72 hours. Seem to have almost 25% incidence of compartment syndrome. I sometimes, if I think the kids are at very, very high risk, will prophylactically release one of their compartments at the time of treatment so that we don't have to bring them back. Synostosis, this is very rare. You need a very high energy injury with a lot of soft tissue destruction, and you don't want to cause this iatrogenically because you can. Neurologic injury, very uncommon, also would be most likely iatrogenic if you're trying to plate it. And you're not careful about your nerve dissection. So, rotational malunion, this is obvious in this case. A very, very bad rotational malalignment. You can see where the radial bow is actually going in the opposite direction. This is completely unacceptable. This needs to be osteotomized and repaired. And this is one that's a very high risk for synostosis. And this could have been easily remedied by just early recognition and treatment. And now instead needs, a big operation. So, cast saw burns, like we discussed, this is what they look like. This is almost always where they occur. These are not cuts. They look like cuts because they're in a straight line, but they're really just occurring in the line of the cast. These are becoming increasingly recognized. These are a big source of medical legal problems, and these are less visible on white children. These are very visible on dark-skinned children because they depigment and they're very disfiguring. And you're at very increased risk here in Detroit, where we have a lot of dark-skinned children. And so you got to be super vigilant about about this. And I would advocate never bivalving a cast unless you can find a zip stick to put in there to protect the skin. So, I know it's late, and it's like I just got to cut this cast, and then I can go home, and I can't find the plastic stick, and trust me, it's like it's going to take you an extra 5 or 10 minutes, and it's going to be worth it, because when you get deposed by the attorneys, that's going to be hours and hours of your life that you wish you had back in exchange for the 15 minutes that it was going to take you to find that little plastic stick. So, indications for internal fixation, there are a lot. So fractures open, you need to get stability. If there's a compartment syndrome, you need to have stability for the fracture as well. If you can't maintain an acceptable reduction, you have to fix them somehow. Polytrauma, you need to stabilize as many bones as possible in a polytraumatized patient. Floating elbow, so supracondylar humerus fracture above either a single bone or both bone forearm fracture. In cases of neurologic or vascular compromise, to protect your repairs, you need to stabilize those bones. And then refractures with displacement. Refractures need to be treated aggressively with, usually with internal fixation. And internal fixation can be intramedullary or plate fixation. So implant choices. These are the workhorses for us of pediatric forearm fracture. So intramedullary nails or K-wires. So we use flexible nails. They're titanium elastic nails. For the smaller children, you can actually take a K-wire and just cut off the sharp tip and contour it and use that. And I've done that many times. It's a little more rigid than your titanium nail because it's made out of stainless steel. Provides very good stabilization. And you have very little soft tissue dissection. The implants are very easily removed, as we'll find out today. And then you can augment them with a very short-term above elbow cast if you want, for a couple weeks. And then you can take them out, and then they have the internal stability. They can start moving their elbow and their wrist very, very quickly. Some people advocate the use of plates and screws. I've never really advocated this very much. I think the refracture rates are much higher with plates and screws. And I think if you know how to use flexible nails, you can actually use them for a very, very wide group, even up to age 15, 16. But it really depends on your comfort with the use of flexible nails. So you can do single bone fixation of both bone forearm fracture. If one bone fixation lines up the second bone, then you do not have to stabilize both of them. If the second one is still unstable or unacceptably aligned, then you can fix that one. And you can fix either bone first. Certainly start with the easier one to fix. And then the ulna is definitely the easier one to begin with because of its straightness. I don't like to do that because the nail that you use in the ulna is smaller. And sometimes I find that I have to deform the radius a lot to get it reduced. And then I find that my ulnar nail will end up being actually bent after I put the radial nail in. So I usually start with the radius. And then if I need to fix the ulna, then I can put the straight nail in without really any worries that it's going to be bent as a result. So this is typical appearance. You can put your the radial nail in always goes in distally. The ulnar nailing can go in distally or proximally, whatever you're more comfortable with. And for the ulna, you'd like your nail the nail entry to be as far away from the fracture as possible. For the radius, you don't really have a choice. It has to start distally. If your fracture is metadiaphyseal, that can be a problem. So like we said, you can insert the rod into the lateral surface of the proximal ulna, and the alternate is the tip of the olecranon. You don't have to go at the tip of the olecranon. You can go just proximal to that. So, and I've done this plenty of times, and it works very well. Radius just proximal to the radial styloid. And just make sure that you avoid injury to the superficial radial nerve. So just dissect down so that your entry point is at the bone and not above. And some people used to use an entry point at Lister's tubercle. Problem is if your nail is proud there, then it's going to rub on the extensor tendon, and I've seen some extensor tendon ruptures, which then are worse than your original fracture. So would not recommend those. Typically, you have a little curve to your nail tip so that it'll bounce over the cortex. This is very soft bone here, and you have to be very careful when you're inserting that you don't go through that. I've seen that done many, many times. So, your radial nail needs to be pre-bent to about 3 times the radial diameter. So you measure this. You measure the diameter of the radius from side to side, and then put 3 times that into the bow of your radius, and that usually is adequate for reducing your radial bow. And then you sometimes have to do a mini open reduction before you do too many passes across the fracture, and then once you get the rod to the fracture site, you have to be very careful to kind of just give yourself your best shot of getting across. You don't want to do too much of this pushing and plunging, because then you may get a lot of swelling in that area and increase your risk of compartment syndrome. And you'd like to leave your nail out a little bit for later retrieval. Complications of IM fixation, infection, pretty rare. Delayed union. Really caused delayed union and non-union. And I had a lot of these early in my practice, and I think it comes from using an oversized nail. So if you use a nail that's way too big, this can be the risk. Ever since I started undersizing to about 80% of your canal size, never had any more of them. Prominent hardware, pretty common problem. I would say this is not necessarily a complication. It's to be expected in many cases. And you should mitigate that by making sure that it's not so prominent that they can't function. Hardware migration can happen. Loss of reduction also can happen. Compartment syndrome, like we said, much higher risk in the open fracture subtypes. So, plate fixation, this is anatomic reduction in absolute stability. Could also be used to bridge comminution. Much older patients, if you have a big open fracture, I would use this. Also, some of the metadiaphyseal injuries, this can be a useful fracture, a useful treatment because it gets you a much better reduction than a nail fixation will get you. No surprises here. You need to understand your anatomy better, obviously, for extensile exposure. Open fractures, the treatment has evolved over the years. You'd like to get to these within 24 hours. I think immediate treatment's no longer necessary as long as the antibiotics are started as close to the time of injury as possible. The surgery can be within 24 hours. Open metadiaphyseal fractures can be treated any one of a number of ways. So K-wire fixation is still certainly acceptable. Plate fixation is acceptable as well. IV antibiotics for 24 hours, and then you can decide on whether you want some additional oral antibiotics for a couple of days. Implant removal, we do a lot of this. IM nails can be removed very easily without any risk of refracture. Would recommend that you only do it after complete solid healing. For me, it's closer to 9 months. Plate fixation is much more problematic because you've got all these stress risers at all the screw holes. So in older children, if they're over age 10, plates and screws are usually not removed unless they're symptomatic because of the risk of refracture. And if you do remove them, they have to be careful and protected until those holes are filled in. So, particularly unusual subgroups of forearm fractures, the so-called Galeazzi fracture. So it's a radial shaft fracture with a distal radial ulnar joint injury. And this is where you see your ulna kind of sticking up in the air. You've got to watch out for these because these can look like relatively benign injuries, but then have a lot of wrist complaints afterwards. So these are usually at the junction of the middle and distal thirds. The distal fragment is typically angulated towards the ulna. Most of these are treated closed, but you need to check on the position of the distal radial ulnar joint. And when you take a lateral x-ray and you see that the ulna is sticking up in the air, you need to address that. And if you can address that with a cast by supinating your cast and then having it reduced, then that's fine. You don't have to do anything else. You just need to immobilize them long enough, because if you don't, then they're going to have complaints. And if that ulna does not reduce, then you probably need to take them to the operating room to pin that distal radial ulnar joint, because otherwise they're going to complain, maybe not now, but a couple years down the road. And that's, I think, one of the big unrecognized things in distal radius fractures that people are doing patients a disservice by. So the other thing is, don't forget that the distal ulnar physis is not ossified at not even visible until age 5, and the distal ulnar physis is not very hardy, has a high incidence of growth arrest. So here's a typical Galeazzi fracture. You can see the distal radial ulnar joint is no longer together. The ulna is straight, the radius is up, and you need to get these two back together and realigned. So here's a Galeazzi equivalent. So here's a case that was missed. Okay, so here's the radius. It's casted. Everyone's like, "Oh, it looks good." Okay, but something's clearly not right here, and the DRUJ is not anatomically aligned, and there's something right here that has not been, just because it's overlapped, you can't see it. But this is the distal ulna that is now displaced. So, and once you put everything back together again, that's anatomic and normal. So distal radius fractures, super common injury, most common fracture in children. Why? Because it's the most rapidly turning over bone in the body, and because when you fall in your outstretched hand, this is taking your entire body weight. So it's the most common fracture in children, 30% of all fractures, with the metaphyseal injury being the most common, the distal radial growth plate second most common. Simple fall is the most common mechanism, and the metaphysis is definitely weaker because of the rapid turnover of bone there. So, and we've talked about these fracture patterns, the metaphyseal fracture pattern, Physeal pattern, so growth plate fracture. Salter-Harris 2 is the most common. Torus. So geometrically, a torus is like a donut shape. So that's where the bone is sort of compressed, like a tube being compressed at two ends and then buckling, and then you create this sort of like donut shape that's pushing out, bulging out on all sides. The Greenstick we talked about, and then the complete fracture. So, what are the differences? Metaphyseal fractures have less compromise of the carpal tunnel and less pain. The growth plate fractures have more compromise of the structures in the carpal tunnel, more pain, can have sensory changes. I saw a child who had a completely non-displaced Salter-Harris 2 fracture, who was never seen, presented the next day with a full-blown compartment syndrome. And that was a complete shock to me, because he had fallen off his roller skates and just presented with like his hand like this, forearm rock solid, and all he had was a non-displaced Salter-Harris 2 fracture of his distal radius. And so compartment syndrome is one of those strange things that's very difficult to completely wrap your head around, because you think it would make sense. So here's a metaphyseal injury that's in bayonet apposition, and this is very well tolerated. And the child will have very few complaints. You can actually leave them like this. This is Salter-Harris 2, and most fractures are Salter-Harris 2. It's very rare to get a true Salter-Harris 1, because they usually take a small piece of metaphysis with them. But here, the carpal tunnel is compromised. The median nerve is kind of doing this little S-shaped dance right now. They're almost certainly going to have carpal tunnel symptoms, and this needs to be treated relatively soon. So, associated injuries, like we said before, distal ulnar metaphyseal fracture, ulnar styloid avulsion. Ulnar styloid avulsions are seen a lot. You don't do anything about them acutely necessarily, but they can be the source of persistent problems later. Distal ulnar physeal injuries, median ulnar nerve injuries, pretty uncommon, but acute carpal tunnel syndrome can occur. So here's an example of a sequelae of a distal ulnar physeal injury with an attendant sort of post-traumatic Madelung's deformity. So treatment of non-displaced distal radius fractures, short arm cast, 3 weeks. Torus fractures, stable. You can treat them with a removable splint if they're comfortable. If they're not comfortable, then put them in a cast. But certainly no more than 3 weeks. Displaced distal radius fractures, like we said, closed reduction treatment. Usually you can put both your thumbs on this fragment, be it the Physeal fragment or not, and push it over. Again, same thing. You want to optimize your chances of success. Put them in finger traps. Give yourself counter traction. Do a hematoma block. And then give yourself one good push to get the fracture reduced. Make yourself a nice cast. And I think most of these can be treated with a short arm cast. The thing to ask them is if they have pain with pronation and supination, then I would put them in a long arm cast. If you think the distal radial ulnar joint is not anatomic, then I would supinate them as well. And then that you need obviously a long arm cast for if you're going to supinate them. But they don't need more than about a month of mobilization. So the reduction maneuver for growth plate injuries, like we said, finger traps, and just do the hematoma block, put the finger traps up, put the finger traction, and then go do your paperwork and come back because it's the time and the traction that's going to help you. So and.
You would do this reduction with the hematoma block as opposed to conscious sedation?
I mean, whatever you're comfortable with, but for me, in my training, we used to do hematoma blocks on whatever we could do because I didn't have to wait for the ER attendings to set up the conscious sedation for us. Or the nurse who was going to give me a hard time and be like, "Well, I have 10 patients ahead of you." Yeah. Okay. So if you can do a hematoma block, then you can do it by yourself. And if you get it in the right spot, they're going to be very comfortable, right? And if you use traction, then it's going to do the job for you. So if you get a nice aspiration of blood and you put all your medicine in, then they're going to be comfortable for your reduction. Obviously, for both bone fractures, it's not going to work. But for distal radius, you should never need conscious sedation, because they will be completely pain-free for this treatment. So repeated reduction attempts are not a good idea for distal growth plate fractures, you really should get these things with one shot. And if you don't get them, then you're going to just have to accept them where you got them to, because repeated reduction attempts are where the injuries to the growth plate occur that are permanent. If you take someone to the operating room with a growth plate, with a malaligned growth plate, you're basically saying that this kid is done growing and I'm just going to realign this thing right now so that they don't have to remodel, because multiple reduction attempts at the growth plate are almost certainly going to result in a perfect sort of some type of permanent growth plate injury. So if you have growth remaining of a couple years, then you can accept about 15, 20 degrees. So I believe if you have enough growth plate to have a growth plate injury, then you have remodeling potential. So you have to look at the child, kind of look at them, look at their Tanner stage, look at their face, look at their parents, try to decide how much growth they have remaining. So here's a 12-year-old with like a 30-degree angulated fracture, and there he is at 6 months. Fairly good remodeling. I think they're going to have a good result. And they were left where they lied. I think it's a good idea to not take them to the operating room and try to reduce that, because if you kill their remodeling potential, then you sort of bought whatever you could get for them. So the sagittal plane remodels very nicely. The coronal plane also remodels very nicely, but rotation does not remodel really very much at all. So how do we care for these? So X-rays. I do X-rays every week for a couple of weeks, and then beyond that, I really don't do much until they're fully healed. And I wouldn't remanipulate a growth plate fracture beyond a week, maybe 10 days. Complications, growth arrest, pretty unusual after distal radial physeal injury. Can happen. It happens to the ones that you don't expect. Probably has to do more with the force that occurred at the time of the injury than anything else. Malunions, pretty rare. They'll usually remodel. I would recommend following them for at least a year before you consider any kind of osteotomy to correct. Shortening, usually not a problem in the radius. Can be a problem, more of a problem with extra growth in the ulna. So if your radius shuts down and your ulna is growing too long, then you may have to shut down your ulna to keep yourself from getting an ulnar positive problem. So here's a typical case. You've got distal radial physeal injury. You've got a radial growth arrest. And if I had seen this, what I would have done would have been to shut down the ulna as soon as I saw that, so you don't end up with this significant ulnar positive and ulnar carpal impingement. But if that's the case and that's what you have, then what you'll have to do is shorten your ulna, which is a pretty easy operation. So, and you just remove a few millimeters from the ulna so they don't impinge, and they'll do just fine. So, again, it's the most common growth plate injury. Increased rate of growth plate abnormalities with 2 or more reductions. The growth arrest rate about 5%. Acceptable alignment about 50% apposition, 30 degrees of angulation, and accept malreduced fractures on late presentation. So, indications for operative treatment: can't get an acceptable reduction, open fractures, displaced intra-articular fractures, which are not that common in kids, but they do occur, associated soft tissue injuries, floating elbow, so associated other fractures, or an acute carpal tunnel or compartment syndrome. So your fixation options: smooth K-wire fixation across the growth plate. This is the workhorse for all of these. Plate fixation for the metaphyseal fractures if you can't get a good reduction. External fixation for a really severe soft tissue injury. I would say that we don't do this that much. I think if even in cases of severe soft tissue injury, we would probably plate these and then put a vac on them, and then if they need a flap, they would do that. I think that's becoming more of the standard of care for these. I'm going to stop here because these are hand injuries at this point, and we'll leave these to Dr. Lochner. So, any questions? Okay, well, thank you very much.
Thank you.